So the next one we have done with the leukemias now. Let's move on to the myeloproliferative neoplasms now. So under myeloproliferative neoplasms, as the name suggests, there is going to be proliferation of the myeloid cells. Okay, so we have 4 classes under this. First one will be the chronic myeloid leukemia, CML, then polycythemia vera, then essential thrombocytosis, then we have primary myelofibrosis. Okay, so if you see, all of these are going to be kind of an interrelated kind of pathology because everything is going to have a myeloid proliferation. CML is the only one in which we have Philadelphia chromosome positivity, right? Philadelphia chromosome is the characteristic finding, translocation 922. So that is the characteristic finding which we see in CML. So in rest of the myeloproliferative neoplasms, there is going to be Philadelphia chromosome which is negative. So there is no Philadelphia chromosome positivity here. And these 3 are going to be associated with JAK2 mutation. Okay. JAK2, we read it was seen, we read it in neoplasia, right? So it is associated with this myeloproliferative neoplasms I told there. So this polycythemia vera, essential thrombocytosis and primary myelofibrosis are the ones which are associated with this JAK2 mutation. Okay. As such, these 3, the chronic myeloid leukemia, polycythemia vera and essential thrombocytosis, they can transform into this primary myelofibrosis in their spent phase. So initial phase of proliferation will be there. Later on, it is going to have a spent phase. So in that spent phase, it can transform into all these 3. First 3 are going to transform into the primary myelofibrosis. Okay. And as such, all the 4 can transform into acute myeloid leukemia. So MPNs can transform into acute myeloid leukemia. And here the least common of this will be the essential thrombocytosis. Essential thrombocytosis has the best prognosis in the case. Okay. So ET cannot, all of the 4 can transform into AML, while ET has the least chances of transforming into the AML. Okay. So now let's start with chronic myeloid leukemia, CML. So I have already repeated this many times. So CML is going to be associated with a balanced reciprocal translocation 922, because of which there is going to be fusion protein of BCR and ABL. So this BCR-ABL fusion is going to result in an upregulated tyrosine kinase activity, which will result in the proliferation, especially of this myeloid cells here, myeloid and megakaryocytic cells. So these myeloid cells and megakaryocytic cells are going to proliferate in CML. So this tyrosine kinase activity can be inhibited by the drug imatinib mesylate. So this we saw it in oncogene addiction, right? So the treatment for CML will be this inhibition of this tyrosine kinase inhibitor, which is with imatinib mesylate. So this again, I'm just giving a recap here. So this translocation 922 can be seen in CML, ALL as well. So in CML, it is going to be a 210 kilodalton protein, while in ALL, it is going to be a 190 kilodalton protein, while in 230 kilodalton protein, it is going to be associated with increased neutrophils. Okay. So what are the classical features of CML? Usually it is a elderly or around 50 to 60 year age group person who is coming up with a massive splenomegaly. So the history will always have this massive splenomegaly. Okay. So what are the findings which we see in CML? If you look at the peripheral smear, there is going to be lots of, there is going to be leukocytosis in the first place. So leukocytosis will be there, and there will be lots of myeloid cells, and myeloid cells starting from myeloblasts till neutrophils, all the lineages will be present. Okay. So left shift we call it as. So myeloblasts, promyelocytes, myelocytes, metamyelocytes, band forms and neutrophils, everything is going to be present, and here the maximum cells is going to be the myelocytes. So we call it as myelocyte bulge. Okay, myelocyte bulge is going to be there. So the myeloblasts are going to be classically less than 10%. Okay, and the most important thing here in CML is there is also proliferation of eosinophils, basophils, and monocytes. So the most important one is this basophils. So both eosinophils, basophils, and their precursors, which is the eosinophilic promyelocytes, myelocytes, all of this is also going to proliferate. So this is the characteristic image of a CML. If you see here, so this cell is a mature neutrophil, right? And here if you see, this cell is having a D-shaped nucleus. So this cell is having a characteristic D-shaped nucleus along with the granules. So this is going to be a myelocyte. And this cell here, if you see, this cell is a large cell, and here it is having nucleolus. So it is going to be a myeloblast over here. Okay. Then apart from that, you are having some cells which are having indentations as well. Like in this case, this nucleus is having an indentation. So this will be a metamyelocyte. And as such, if you see, this cell is a eosinophil here, and this is a basophil here, And these cells, if you see, the granules are quite coarse and darker and have a different color, right? So this is a eosinophilic precursor, while this is a basophilic precursor. Okay, so this kind of increased leukocytosis along with multiple precursors, along with increased eosinophil and basophils with their precursors, is the characteristic image of a CML. So because this is having a multiple kind of an appearance, like different kind of cells is present, this is called as college girls appearance. So multiple color things are there. So it is called as college girls appearance. While in CLL, if you saw, it was all monotonous, same kind of lymphocytic population, right? So that is going to be called as a monotonous population or a schoolgirl appearance. So schoolgirls are going to wear uniform, right? So schoolgirl appearance is CLL, while college girl appearance is going to be CML. Just fancy names, okay? So in bone marrow, if you see, again, there is going to be increased cellularity, again with the myelocyte bulge over here. Apart from that, this kind of cell, which is called as the pseudo-Gaucher cell. So in genetics, we were discussing, right? So this pseudo-Gaucher cells or sea blue histiocytes can also be seen in bone marrow. So these are nothing but histiocytes. They have this crumpled tissue paper appearance, and this is actually because of the increased cell turnover which is seen in CML. It is having this lipid accumulation is going to be there in the histiocytes. So that is why it is called as pseudo-Gaucher cells, which appear like the Gaucher cells. These are nothing but the sea blue histiocytes. And if you do a lab score, which is a leukocyte or a neutrophil alkaline phosphatase, if you do the stain and you count it, this lab score is going to be decreased. Okay, so this is the characteristic finding. Again, in CML, lab score will be decreased. So the normal score is usually 40 to 100, and here in CML it is going to be decreased, even 0. Okay, so you can do a FISH or a molecular technique like PCR to diagnose this translocation 922, and FISH is going to be the investigation of choice to identify the translocation. And with PCR, you can find the number of BCR ABL transcripts, for which we can identify, with which you can identify the minimal residual disease. So what are the phases of CML? So we have a chronic phase initially. Chronic phase is going to be a phase in which the blasts were going to be less than 10%, right? Then there is an accelerated phase wherein it is going to have an increased risk of going to be transformed into blastic phase. That is an acute leukemia. So chronic phase is a okay type of phase. Then it goes into an accelerated phase, which is a danger phase, and then it reaches into the acute leukemia phase. So in accelerated phase, you have a specific criteria to diagnose accelerated phase. Here the blast count will be between that of the chronic phase and the acute leukemia phase. So it is going to be 10 to 19%. So 10 to 90% blast along with increased basophilia. Increased basophilia can also be present in chronic phase, but the basophils count should be more than 20% in a accelerated phase. While platelet count can either be decreased or increased, that is less than 1 lakh or more than 10 lakh, which is persistently present, which is not responding to imatinib treatment. Okay, so splenomegaly again, splenomegaly and leukocytosis again, which is not responding to treatment. So platelet counts, then leukocytosis, and the splenomegaly, which is unresponsive to treatment, is again characteristic for accelerated phase. Apart from that, additional cytogenetic abnormalities. So apart from translocation 922, they can also acquire certain other mutations like trisomy 8, isochrome 17q. So these are again going to be called as accelerated phase. Then comes the blast crisis. So blast crisis, there is going to be blast more than 20% over here, or they can form chloromas directly. So chloromas are diagnostic of acute myeloid leukemia, right? So chloromas can be formed, or in the bone marrow biopsy, if you see large clusters of blasts. So these three are the criteria to call it as a blast crisis. And usually the blast crisis, they become acute leukemia, right? So the acute leukemia, it is 70% of the time it is going to be AML, and 30% of the time it can be ALL. Okay, so don't think CML can only become AML. Both are myeloid, right? But 30% of the cases in blast crisis can transform into acute lymphoblastic leukemia as well. So coming to the differential diagnosis of CML, if you see the peripheral smear in a leukemoid reaction, so leukemoid reaction is nothing but in a septicemia, if you see, there is going to be lots of leukocytosis. But here the leukocytosis is here is going to be less than 1 lakh only. In CML, usually the count is going to be more than 1 lakh, while in leukemoid reaction, it is going to be less than 1 lakh. And as such, the cells which are proliferating, again myeloid left shift will be there, but it will not go up till the myeloblast. It will maximally go up to the promyelocyte maximally, usually till metamyelocyte it will go, and the bulge here will be that of the neutrophils band forms rather than the myelocyte bulge which we see in the CML, okay. And there is not going to be basophils. So basophils, increased basophils, it is quite characteristic for CML. Apart from allergy, if you see it in the characteristic picture, it is basophils. If you are seeing in the peripheral smear, it is going to, you'll have to think about CML first. So there is not going to be any basophils in leukemia reaction, nor any organomegaly, or any the best thing will be the lab score. So lab score here will be elevated. So lab score was characteristically decreased in CML, while lab score is elevated in leukemia reaction. And then obviously the Philadelphia chromosome will be, if you test for it, it is going to be negative, translocation 922. Then you can also see the presence of Dole bodies. So Dole bodies can be seen in the neutrophils. So these are nothing but endoplasmic reticulum remnants only. So these Dole bodies are usually seen in sepsis. So the remnants of rough endoplasmic reticulum can be seen.